Anandi is a concurrent consultant and cardiographic consultant at Punjab.
For the kind introduction. Firstly, let me explain that this is going to be a marathon. In fact, the topic given to me is quite lengthy. In fact, it is basically 4 things, and I was asked to cover 4 things in just one lecture, and almost half of the diagnostic cardiology, and this is complete non-invasive diagnostic cardiology. So I'll be just touching a few things, and mainly I'll be concentrating to this part of the things. But since I was asked to talk about, do you hear me? All right. So since I was asked to talk about exercise tolerance stress and stress Thalium, which is being cardiologist, yes, I'm interested in, but not in my specialty. So I have to, just a brief of this. Well, let's talk about the facts of this topic. In fact, this excluding echo, the whole subject of today's lecture gives an impression of evaluation of ischemic heart disease, since it covers ETT, stress Thalium, stress echo. So they are mainly related to the topic of ischemic heart disease. And echocardiography has a wide spectrum, and it's obviously its indications and spectrum is beyond ischemic heart disease. This is just one indication. Ischemic heart disease is just one indication of echocardiography. So that's why I have given my excuses. So I have to rush through a few slides just to cover up the things in a appropriate time. So ischemic heart disease, when it comes to a diagnosis, there are 3 important things. Its presentation is either it is a history of angina, or patient is just complaining of chest pain, or patient lands in your clinic or in the emergency room with a definite angina. And thirdly is patient might be having history of previous infarction. So taking these factors along with what should be what is the algorithm, what should be your approach to the patient while coming to the clinic or in the emergency room. So if you're suspecting history of angina or there is chest pain, you have to go on to evaluation of whether these symptoms are purely ischemic or non-ischemic things. And you can plan the stress-induced reversible ischemia, whether the patient really has this symptom related to a pathological disease behind it, or it is just a non-cardiac presentation. So you have to establish that in this situation it should be stress-induced thing. And it could be simply physiological or maybe pharmacological. And this physiological situation, how it covers, basically the severity of the disease that correlates very well with the severity of the coronary artery disease. So while interpreting the results, you should also keep this factor in mind, because next we are going into diagnosis. So while to interpret these things, you must be aware of the things. When it is a mild disease, the ischemia on stress induction would be delayed in onset and early to recover. Whereas if this is a long-standing or it's a severe disease, then its presentation would be early during the test and recovery would be delayed. So if you get a report, if you advise some test and you get a report and this important feature is written there, you can evaluate how severe the disease is. So physiologically talking about is ETT, just referring the patient for treadmill, physical exercise, or this can be evaluated through stress Thalium along with the treadmill, or maybe with the stress echo. And the other thing is, if there is some limitation, which we are going to discuss in fact in the coming of slides, if there is some limitation to do the physical exercise, then obviously you can subject the patient for pharmacological stress, and that is obviously using different kind of drugs dobutamine, maybe dipyridamole, maybe adenosine. So there are so many drugs, and that pharmacological stress can be performed through stress thallium or stress echo. If the patient, this is the situation when there is a suspicion of ischemic heart disease. If the patient lands in the emergency and the diagnosis is not clear, patient is complaining of chest pain, obviously echo at rest can guide you whether the patient is having ischemia or not. If the patient has previous history of infarct landing into your clinic, you can plan for further evaluation. If you are interested in regional wall motion analysis and LV function, then of course it could be echo at rest for function and wall motion. If you are planning for the status of ischemic heart disease and its complication, obviously echo at rest. But if you are planning to study it further for prognosis, for risk stratification, or to study the viability, obviously you have to go for stress thallium or stress echo. Right, there is ischemic cascade, how the ischemia presents. This is a big workload and stress starts. When the stress starts, very next thing which changes are, there is perfusional heterogeneity in the coronary arteries. The blood supply is disturbed. And what happens next? There is metabolic alteration. So the changes takes place, and what happens is there is a diastolic component of the ventricle is disturbed, and still there is stress going on, and then is the regional dysynchrony, that is the regional wall motion abnormality comes in, and then comes the ECG changes. In fact, now you understand the ECG changes come quite late, where the ischemia has started right from the first step. And that is why sensitivity of ECG is quite low as compared to other modalities. And then chest pain. So the symptom of the patient comes quite late when the ischemia is already established. So what to do and where to do and where the things come in. ETT has a role up here when there are ECG changes. So when you subject somebody to go for treadmill test for to evaluate reversible ischemia, that means you are going for a low sensitivity situation, because what you are going to evaluate is his physical status as well as ECG changes. But a thing comes quite early is the echocardiography, and echo plays a role up here. There is diastolic dysfunction and regional dysynchrony. So if the patient is in the emergency and that the ECG is normal, that does not mean the patient does not having cardiac symptoms. You can do, or you can suggest echocardiography, and if there is new diastolic dysfunction or if there is any regional wall motion abnormality, that means the patient is having ischemic heart disease. And third thing is stress thallium. It is not a test to do in the clinic or in the emergency. Obviously it's a planned test, but it has as compared to routine echo or echo at rest, it has a good sensitivity to pick the things quite early. So sometimes it can overestimate the things. It may pick up the simply pathological or aging phenomena rather than a clinical scenario. So this thing you have to keep in mind before interpretation. What my lecture is basically your idea to prescribe the test and to interpret the reports. I'm not going into the details as you are not going to be the performer. Now, first thing we are taking up ETT. Obviously, ETT is a physiological, it's a method of choice, easily to be performed. And indications, class 1 indications are the absolute indication for ETT, and this is initial evaluation with suspected known coronary artery disease, maybe chest pain, maybe right bundle branch block, maybe resting ST depression less than 1 millimeter of mercury. Of course, in this situation you can straight away prescribe patient to go for ETT. Known coronary artery disease, evaluation due to significant change in the clinical status. If the patient is already having known history of ischemic heart disease, already taking medicine, you want to assess his physical status, how much he is handicapped, and how is the quality of life being affected, or whether the ischemia has progressed or it is static, you can evaluate. And then third is low risk unstable angina, 8 to 12 hours. You can prescribe 8 to 12 hours after the initial presentation. And intermediate risk, obviously 2 to 3 days after presentation. Class 2B is, in fact, class 2B is where you are a bit reluctant. In fact, it is not a clear-cut indication, and it is not going to give you much benefit, in fact. And that is in the cases of WPW syndrome, pacemaker, and all these things. Let's rush through these things. Contraindications: absolute, acute MI within 2 days, high risk unstable angina, uncontrolled cardiac arrhythmia, severe aortic stenosis, significant heart failure, acute pulmonary embolism, acute myocarditis, pericarditis, acute aortic dissection. These are the absolute. You should, even if you're just thinking of these things, never ever prescribe EGT. And relative, obviously, left main stem disease, obviously this is a severe entity, moderate aortic stenosis, electrolyte imbalance, severe hypertension, tachycardia syndrome. How come? Mentally or physically disabled person, anybody who cannot perform exercise, obviously you are not going to subject that patient for ETT. Now, what ETT gives you is, you have a suspicion in mind of coronary artery disease. If there is any contraindication to the stress testing, yes, contraindication is there, go straight away for coronary angiogram. If there is no contraindication, just think whether patient can exercise. No, then go for pharmacological imaging like stress echo or stress Thalium. But if you think that patient can exercise, yes, then is resting ECG interpretable? If no, go for again stress imaging, because your ETT is based on ECG. So if you cannot interpret this thing, there is no need to go further, and you can go for stress imaging. But you have done the patient ECG and the signals are not clear. It is not interpretable. So if this is at resting, not interpretable, when you put on the physical activity, there will be totally chaos. You can't see the signals, you can't see the waveform clearly. So it will be just a waste of your time. And so if resting ECG is interpretable, subject the patient for ETT. But before going for that, just think whether your diagnosis or prognosis is going to be certain or not with this test. If no, go for the modalities of imaging. Sorry for this color, in fact. This is stress imaging basically, or coronary angiogram. You can make either of the choice. But if it is, yes, interpretable, diagnosis and prognosis would be clear after ETT, then go for ETT straight away, and afterwards you can continue medication, you can initiate medication, you can modify medication. So this should be the algorithm to plan for ETT. Now next, coming for the stress Thalium. Stress Thalium application of nuclear cardiology is a long list, in fact, but basically it has much superior role in upper these two things. Rest of the things, in fact, echo has taken over, even resting echo has taken over all these indications. So coronary artery disease and assessment of LV or RV function, obviously this is the best indication of nuclear cardiology. And that's why this coronary artery disease, diagnosis, assessment of prognosis, risk stratification, assessment of myocardial viability, assessment of revascularization procedure, and acute chest pain management in the ER room. This is just a comparison about different techniques, and you can see the exercise ECG, the sensitivity and specificity of 68 and 77%. Whereas if you are going for stress Thalium, it's 81% and 87%. The other drugs, maybe and tetrafosmin, again this. But look at the things. I'm not, in fact, promoting my specialty, but I'm just comparing the things. Look at the stress echo. This is the stress echo, 87, 89 and 90, giving a very good sensitivity, head-to-head comparison with stress Thalium. So it is easy to perform, cost effective, does not require much of the preparations, and of course obviously this is operator dependent, but as far as technology is concerned, it is much cheaper, and one can avoid radioactivity as well. So this is it.
Can you explain a little more the stress echo, how it's performed?
We'll go to that subject. In fact, we are just going step by step. I'm just taking you to the point, in fact. Now this is just a normal scan going through all the areas are perfused, and basically nuclear cardiology is on the basis of, as we have seen in the first slide, it is on the perfusion of the myocardium. So it is not in fact the physical change, that is wall motion change in the ventricle. And since this is perfusion, there are so many factors which you can straight away challenge. This is just looking at the LAD territory. You can see the ischemia. This is left mainstem, marked ischemia all around. So just a few things to show you. In risk stratification, you can judge if the results are low, less than 1%. So risk of death is very low, 1 to 3. High probability scan, risk of death is more than 3% per year. So you can use it for the risk stratifications. High risk features of Thalium. Following features demonstrate if you receive the report, you must go through these features. Then post-stress, what was the ejection fraction, how the ventricle behaved, whether it dilated, what kind of the defects, whether fixed defects, dilatation was there. So if these things, that shows that the patient is at high risk or having severe coronary artery disease. It has a very established prognostic role in the coronary artery disease, angina, women diabetes, post-MI, post-revascularization, post-operative screening of non-cardiac surgery. Now coming to the echocardiogram. Where do we stand as compared to these two techniques? Just talking about the echo at rest, just a little bit, and then going on to head-to-head comparison with the previously described modalities. It's a unique modality, ability to provide diagnosis that may not be apparent to a clinician. And thirdly, it is definitive rather than a screening diagnostic tool. So you should be very clear-headed when you are prescribing echo, that what are your aims, because it is going to give you, it has definitely an advantage over other modalities. It is going to give you a definite diagnostic clue. There are different modalities of echo: transthoracic echo, transesophageal, tissue Doppler imaging, stress echo, echo with contrast agent, fetal echo, strain rate imaging, and this is something new, is cardiac resynchronization, role of echo in cardiac resynchronization therapy. Alhamdulillah, we are doing all these modalities in PIC, excluding you can say up to this point. These two things, in fact, I have just started in PIC, and I'm already working on a project in the private sector with the Doctors Hospital and Aga Khan. In fact, we are the first one in Pakistan, me and Dr. Farhan, electrophysiologist, to work on this kind of thing. This is basically biventricular pacing of the ventricle in severe cardiac function, which is a good treatment. So we have done about 15-20 cases and very promising results. This is cardiac resynchronization therapy. This is basically you go for when there is it's used in cardiomyopathies, when there is LV dysfunction and the patient is refractory to the treatment. So the choice previously was left with cardiac transplant. But now there are studies, and this is proven, that try to evaluate whether this severe dysfunction in this situation, whether all the regions of myocardium are moving synchronously or there is some dyssynchrony. Because it's like an example, few people are just pulling a cart, and if they are moving in the same direction, pulling all together, they can move the thing. But if they are not synchronous with each other, so how much they are putting the pressure, they cannot move that cart. So you have to first evaluate whether the cardiac segments are synchronous to each other or not. If they are synchronous, then obviously you can't offer anything. This is a sweet disease, finished. But if you document that there is some dyssynchrony, there is a mismatch, one is both the segments are contracting but not at the same time. So what you do is you go for biventricular pacing to synchronize those segments, and this is how, when they are synchronized, you improve the ejection fraction. So this is a new concept, and this is very effective. And people are, I mean, they come with a moribund situation and they go home on their feet after this therapy. But now coming on to the topic, transthoracic, and a topic of the day is assessment of ventricular function, especially in relation to the ischemic heart disease. Now, when you get a report, again, my emphasis is prescribing and getting a feedback and then interpreting your results. So when you get a report, look for the systolic and diastolic functions, look for the global and regional function. So systolic function, global and regional. Diastolic dysfunction, global and regional. So go through all these parameters. This will give you, global means overall performance, regional means is there any wall motion abnormality, which is obviously the indication or which is indicative of ischemia in that region. And the same thing is regional diastolic or global diastolic function, dysfunction. So talking about global just a little bit, how do we assess and what we put in our reports? Either it is eyeball impression, which is in fact operator dependent, it is a non-scientific kind of thing. Or this is M mode evaluation, which is most commonly used, or this is 2D imaging, this is modified Simpsons. So in fact there were different modalities people were going through this thing. So this is a basically past and long axis view, and we are using cube method here, taking as left ventricle as a cube and just cutting the section here, and this is what is M mode, and we measure the diastolic component, we measure the systolic component, and ejection fraction is basically end diastolic volume minus end systolic volume over end diastolic volume. And how do we calculate from this? We calculate is that internal dimension in diastole cube minus internal dimension in systole cube divided by internal dimension in diastole cube. So this is the way of calculation. But point is, the limitation of this thing is you are calculating the function in this region. So if there is some myocardial infarction or ischemia distal to this, that this region is healthy but there is distal disease, you cannot pick that up. So it is giving you false results. So what you do, you go on to a modified Simpsons, which is more reliable to date, and though it is for an operator this is a bit cumbersome procedure, but obviously this is a good tool to give you a good ejection fraction. So you calculate it in systolic and diastolic frames. What the idea is, you calculate the length and computer give a landmark, computer would calculate the area for you at different segments, summing up the area, and this is how ejection fraction is calculated. You can do in 4-chamber, you can do in 2-chamber, and that ejection fraction, mind you, is the accurate one. So this is the reliable method. Now coming on to regional systolic function. So whenever you are going to interpret the report, look for the ejection fraction, whether this is calculated through cube method or Simpson method. So if something is put right like this is ejection fraction by Simpson method, that means this is a very reliable report. Now going on to regional systolic function, this is used for coronary artery disease, which is leading to myocardial ischemia, which is of course leading to wall motion abnormality, which we have seen in the cascade phenomena, and That leads to regional wall motion abnormality by echo even without ECG changes. This is just a repetition of the previous slide. What happens is ECG picks, it's a gray zone. Angina, ischemia without ECG changes and mechanical changes. Echo picks, in fact, super silent ischemia. Even patient doesn't have ECG changes, even patient doesn't have angina, just there is a suspicion, go for echocardiogram and it can give you the result, that whether the patient has ischemia or not. This is a basically classical equation. I mean, just to enforce my point of view. I'm not trying to convey this message that when you go home, you should be just thinking of echo and echo and echo and nothing else, so that I or my colleagues should be getting a good feedback from you. No way, no question. I'm talking about the parameters which are standard and used. Previously, the diagnosis of ischemia was chest pain, STT changes, and there was ischemia. Or there was no pain, STT changes, probable ischemia. Chest pain minus STT changes, possible ischemia. No chest pain, no STT changes, no ischemia. But since echo factor has come into this place, it has changed all these equations. Now chest pain with ECG ST changes, but minus regional dysynchrony, there is no ischemia. Full stop. But if there is chest pain, minus STT changes, plus regional dysynchrony, there is ischemia. So this is the importance of echo, or assessing, not echo, but importance of assessing the wall motion abnormality, no matter what method you use. Now, role of regional wall motion assessment. How you do that? Obviously, diagnosis of coronary artery disease, early detection of acute MI, evaluation of regional wall motion abnormality after reperfusion, then detection of post-infarct mechanical and functional complications, assessment of myocardial viability, and prognostic risk stratification. So quite wide spectrum. Now, target of ischemia is subendocardial layer going to epicardial layer. So regional systolic thickening linear to subendocardial ischemia. So the ischemia starts from subendocardial layer extending to the epicardial region. So even epicardium is not involved, still you can pick on echo the changes of ischemia. What are the changes of ischemia? Hypokinesis, akinesia or dyskinesia. When you see a report mentioned these regions are akinetic, this is dyskinetic, this is akinetic, or this is hypokinetic, what does this mean? This means normal systolic thickening of a segment. If this is more than 40%, then obviously this is a normal. Hypo, this falls between 10 to 40% systolic thickening. Mild is 30 to 40, moderate 20 to 30, and severe is between 10 to 20. Anything less than 10% systolic thickening is obviously not considered as a kinesis. So it is an infarcted region. This is akinesia. And dyskinesia is the outward motion. This is, in fact, you can put it other way, that this is dysynchrony. The segment is not coinciding with the other segment. So it has its own independent motion. This is usually seen in the case of aneurysm formation or long-standing scarring or thinning of the region. This slide is just to give you an idea. In fact, sometimes you refer the patient after your evaluation for some kind of intervention, maybe PCI or maybe surgery. And you have a report of echo that patient is having 20% or 30% or 40% ejection fraction. And patient has come after surgery, or maybe may spend a lot of amount in, say, getting stenting done, and then patient comes and you subject the patient again for echo just to see how the things improve. So this slide, in fact, basically the emphasis is that echo may give you the same report as it was before revascularization. That does not mean that that procedure is a failure, because point is, when 25% of the myocardial thickening is involved, is affected, is infarcted, Anything beyond that, that region shows akinesis. So if one patient having just 40% thickness involvement and the other person has 80% involvement, after revascularization, 40% may say after revascularization there is 30% improvement. The patient having 40% thickening, there is improvement, and he falls in the category of 10 to 15%. So that region which was akinetic, it has improved its kinesis and it is showing either normal kinesis or it is hypokinetic. But a patient who is having severe disease, say 80% systolic thickening, myocardial thickening is involved, after revascularization he has improved 30% and he has dropped from 80 to 50%, but still they fall in the category of akinesis, so echo is going to pick akinesis in that region. So don't interpret the technology or technique independently, just associate it or correlate it with the patient's clinical status. If the patient is clinically improved, his quality of life is improved, that does not mean whether your echo report is, straight away don't consider that this echo report is wrong, because these are the things which play a role. So this graph basically shows you anything beyond that, it is negative. So if somebody is up here, he improves up to this region, but still it is akinesia. So that means improvement is definitely there for that procedure, but it has not come back to normal thing. Now this is going on to how do we assess the segment to segment and how is the coronary artery distribution. So this is just a cartoon diagnostic graphic. This is LED territory. This is parasternal long axis view. This is LED territory, septum, and this is a infralateral wall, or you may call it posterior wall. Previously it used to call posterior wall. Now recent there is a change in the guidelines and modification, so it has been labeled as infralateral region. So just divide it into 3 segments: basal, mid and apical. So same thing. So in this region you can see the septum, anterior septum and infralateral region. I'm sorry, I don't have a mouse. I cannot play back these loops, in fact. And there's some problem with the laptop connection to this overhead. So it is very bland. So it's not a crispy kind of thing if it doesn't move. Going on to short axis, at mitral valve level, you can see the mitral right in between. And this called the basal region, and this is divided into 6 basal segments. This is anterior septum, anterior wall, anterolateral, infralateral, inferior and inferior septum. And this is the coronary artery spike. This is LED territory, this is circumflex territory, and this is right coronary artery. So just doing echocardiogram, you can, if you are good at it, you can, going from segment to segment, you can define which coronaries are affected. Going still further down towards apex, at papillary muscle level, these are 2 papillary muscles, and again 6 segments. This is, since this is mid region, mid anterior septum, mid anterior wall, mid anterolateral, mid infralateral, mid inferior and mid inferior septum. Now the LED territory has extended from the previous one to inferior septum to the region of anterolateral region. And this is the right coronary artery, this is circumflex territory. This is reducing and this is increasing. Still further going down, and apex, we divided into 4 segments, so totally there are 6 segments. So this is apical septum, anterior septum, and this is inferior, this is lateral and this is inferior. So this is all LED territory. So if you find is infarction or ischemia of apex, then straight away you can say this is LED involvement. And if there are different other segments are involved, you can go from segment to segment. Same things are being repeated, going for apical 4-chamber view. This is inferior septum, and this is a anterolateral wall, or you may call it lateral wall. So this is circumflex territory, LED territory, and RCA. This is 2-chamber anterior wall and inferior wall. So we scan it from different angles and reconfirm the same segment from the other region, so that we should be very, very sure about this thing, that this region is affected and there is no say false wall motion abnormality. So this is LAD territory, this is RCA. Apical long axis, just going risk stratification. Let's go through this thing. There are certain causes when you can detect a regional dysfunction, coronary, and they are non-coronary causes where you do find regional dysfunction, especially left bundle branch block, WPW syndrome, and patient having previous cardiac surgery, atrial septal defect, and these may give rise to false wall motion abnormalities. So that is why you have to go from region to region, reconfirming that there is a genuine wall motion abnormality of ischemia. Now coming to the stress echocardiography for assessment of ischemia. Indications of stress echo is patient in whom ETT is contraindicated, as we have just seen in the previous algorithm. Severe arterial hypertension, you cannot subject the patient for physical stress. And patient in whom ETT is not feasible due to intermittent claudication, obviously patient cannot walk through that. Patient in whom ETT was non-diagnostic. Patient, you have advised ETT, performed, and it is non-conclusive kind of thing, you can subject the patient for stress echo. Class 12.
Stress is different.
Yes, definitely. In fact, sorry, because that falls in the technology, how to perform it, that's why I've skipped it. But to your question, I must tell you that how we perform it. We do a resting echo, and there is some preparation. Patient should not be on beta blockers or anti-anginal, long-acting anti-anginal drugs. And we use divitamine, in fact, for that, because it is a good, strong, potent inotrope. And we calculate according to body weight the dosage. And with the infusion pump, we infuse, taking the resting echo, then we start infusing 5 microgram per kg per minute. And we, after 3 minutes, we see the response, do the echo. And this is all not a routine echo, this is a digital echo. The acquisition is digital because it's making a very short slices, quick slices. Excuse me, can I have a glass of water, please? Pani. Right. So after 3 minutes, we go incremental changes. After every 3 minutes, we go on to 10, then 20, then 30, then 40, then even up to 50 microgram per kg per minute. And sometimes when we are not seeing any positive response up to say 30 mics, positive response means either we are not getting a wall motion abnormality or we are not getting an increase in heart rate, because heart rate is going to lead to ischemia and to wall motion abnormality. So if we are not getting adequate response, then we add on atropine at 30 or 40 mics. So we give atropine to increase the heart rate, enhance the heart rate. So it takes about maybe 15-20 minutes time to reach to the peak. And obviously endpoints are, if you find ischemia, if there's drop in blood pressure, if you find regional wall motion abnormality, or if you find that achieve the normal target heart rate. So this is how stress echo is performed. And obviously after performing the test, depending upon how early the changes appear, you give certain time for the recovery, maybe 5 minutes, maybe 10 minutes, maybe if say it appeared even in the first stage, and then you try to give it, say, and not recovering after 5 minutes, 10 minutes, you may go up to 20 minutes acquiring the images. And obviously one is, this is direct operator's application, concentration, secretion of adrenaline, and of course after, while reporting, it is basically operator's skill basically. So one has to be really very, very good at interpreting these results, because if there is a inter or intra-observer variation, this is useless. So it has to be good inter or intra-observer, there should be no inter or intra-observer variation to have a good result. So that's how it's different from a routine echocardiogram. So class 1 indications are where it is useful: risk stratification, diagnosis of ischemia in symptomatic patient when ECG is non-diagnostic, assessment of functional significance. The advantage of echo here is over, I may emphasize, over stress thallium is, in stress thallium you are just looking at the volume of the perfusion. But when you are doing echo, you are not only looking at the regional wall motion abnormality, but at the same time you can see the other things, complications like, say, ischemia develops, there may be mitral regurg, there may be some associated problem, maybe diastolic dysfunction. So you can assessing the heart in journal as well. So it has advantage over stress thallium that in one study you can evaluate the structural functional status as well as myocardial ischemia. Right. Assessment of functional significance of known coronary artery lesion is say planning revascularization viability study. Class 2A is where it is probably useful: risk stratification before non-cardiac surgery, especially in cases of renal transplant surgery. We are getting good number of cases in patients where there's going to be renal transplant, so they just want to assess the myocardial status. If this is normal, obviously they should go for that. If not, then obviously first correcting that ischemia and then going for renal transplant. And class 3 is useless in cases of routine evaluation of patient, because this is not something test to be used as a routine or in patient where there is low probability of the disease. Routine risk stratification, screening asymptomatic patients. I mean, this is abuse of technology. Routine assessment of asymptomatic patients after revascularization. Routine periodic assessment of stable patients for whom no change in therapy is contemplated. Factor increasing or decreasing the sensitivity, obviously. Previous MI, absence of antianginal, stenosis severity, multivessel disease, complex LAD territory, maximal stall intensity, variant angina. This is basically lack of hyperkinesis. Basically, this is also important. Sometimes you find a normal response, but in stress there has to be hyperkinesis, hyperresponse. A lack of hyperkinesis is also a positive factor. These are the negative factors. Obviously, the limitation of stress echo is when there is a probability, low probability, or single vessel disease, or stenosis is less than 70%. So in that situation, obviously stress thallium is better. Effect of oral therapy on stress testing sensitivity: beta blockers, calcium channel blocker, nitrates, they do affect. Mainly this is the thing which we avoid because they affect the dobutamine in this situation. This is the dipyridamole, this is dobutamine. So beta blockers are the main affecting because they are an antagonist of dobutamine. Rest of the things are less important, so if patient is taking these medicine, it is immaterial. Contraindications: poor acoustic window, severe hypertension, significant atrial or ventricular arrhythmia, severe valvular heart disease, hypertrophic cardiomyopathy, and obviously use of atropine. When you use atropine, obviously it has its own complications. So stress echo is used in 5 equations: rest, stress, and diagnosis. Normal kinesis, normal response, normal kinesis, hypoakinesia or dyskinesia, ischemia, hypokinesia, akinesia, dyskinesia. Jeopardize: akinesia, hypo or normal, viable tissue, because it's a very good test to assess the viability. And akinesia, dyskinesia, during stress, the same, it's a necrosis, gone, scarred. Viability is another issue of stress echo. So diagnostic measures are basically 3 different pathophysiologies. Stress thallium affects the microcirculation, and this is stress echo is basically about inotropic results. It is the true myocardial wall. So this is what you are achieving, and this leads to, say, hibernating or maybe viable tissue, and you use low dosage dobutamine, and that gives you a wall motion, say, change during the test, and you can straight away subject that patient that this is the patient having infarction, akinesis, but there is still viable myocardium is left, so the patient may be gone for coronary angiogram and ultimately surgery. Well, this is very interesting. Harvey Feigenbaum is basically Babae echo, and he has written so many publications. He has written textbook echocardiography, and according to his version of stress echo, this is it. Stress echo is like a sex. If you have never done it, you cannot know what it is. Once you start, you usually keep on doing all your life. But if you do it and you don't find it fun, there is probably something wrong with you. Thank you.